This is Inside Urology, Cutting to the Chase, a podcast from the Indiana University School of Medicine Department of Urology. We talk about all things urology with Dr. Clint Carey. Each episode features conversations with physicians, researchers, patients, and we'll share some of the stories shaping the field. So let's cut right to the chase. Welcome in to Inside Urology, Cutting to the Chase, Episode 3. Clint and I have maybe a few updates since our last recording. We've released the podcast, so it's out there. It's in the world.
Yeah.
And
we're podcasters now.
We've gotten some good feedback.
Yeah.
No one's shut us down. So
we have had some surprising people come out of the woodworks and say that they've listened. So I think I don't know. Time will tell, but we may be onto something.
Yeah, I think we're winning.
Yeah.
Also, make sure to follow us on social media. We have Instagram and Twitter or X at Inside IU Urology. We'll post updates and just like fun things we're doing, hopefully along the way, when we're going to release new episodes, stuff like that. So make sure to follow along.
Yeah, my kids told me to make sure you said to like, subscribe, and something else I forgot.
Do all the things.
Yeah. Now, we also have to say, I don't know if you're going to bring this up, but we have to say this is, being that we are at Indiana University, we do have to mention this is the first episode that we're doing since Indiana won the national championship in football. I think that has to be mentioned.
Yes, go Hoosiers. All right, well, let's cut right to the chase. We have Dr. Ramzy Burns with us today, assistant professor here with the department. So thank you for being here. We're very excited to talk to you.
I'm excited to be here.
Tell us a little bit about your background and how your work focuses on women's health and women's urologic health.
Yeah, so I initially came to Indiana University for my residency. Prior to that was from Pennsylvania, so I'd never really been here before. And I remember during residency, it was my third year, I was at Eskenazi, which is our county hospital rotation. And I remember being in the clinic, and there were days that just kind of like followed each other one after the other, where every time I would walk into a female patient's room, her eyes would just like light up, and she would smile over the fact that I too was a female and a urologist. And it just resonated with me, I think, after a few days in a row of that I could kind of either run into this and pursue it, or you run away from it, which is what some of my friends have done, where you choose specialties that are specifically totally out of women's health, which is totally fine. But for me, it just made more sense to run into it. And so following residency, I did a fellowship in urogynecology and reconstructive pelvic surgery. During that time, I also got certifications in menopause hormone management. I spent time out at San Diego Sexual Medicine and learned about just really some of the nitty-gritty intricacies of female sexual health as well. And so again, just kind of surrounded myself with as much information as I could so I could provide the best care for my female patients. And so predominantly now my practice is all female. And so I see women for a range of issues: prolapse, incontinence, hormone management, sexual dysfunction, recurring UTIs, interstitial cystitis, amongst other things.
So Ramzy is a relatively new faculty member here with us at IU, and we're fortunate to get her here from the East Coast for residency. We were able to convince her to stay here for fellowship, and we're fortunate to have her on faculty now to help with our female urology patient population. It's desperately needed, big demand for that. And so we're excited for you to be here. We're excited to learn a little bit about our topic today. And so I'll just go ahead and introduce that. So in 2025, they came out with Genitourinary Syndrome of Menopause guidelines from the American Urologic Association. And for those who don't know, that's our big national organization. They have a lot of guidelines on a lot of different diseases across the spectrum of urology that help guide what urologists do and how they treat a variety of patients. And so that's what we're going to be diving into today. And Ramzy is in that field and keenly aware of these. And actually, Dr. C.R. Powell on our faculty was a member of the guideline panel. And so also, for those who don't know, that's a prestigious honor to be a part of something where you're writing the guidelines that's going to affect how we care for patients.
So tell us a little bit about what exactly is genitourinary syndrome of menopause and what kind of symptoms?
Yeah. So initially, the verbiage for genitourinary syndrome of menopause was actually coined vaginal atrophy. And so in 2014, a collection of groups got together and basically came up with new name for the previous name, which was vaginal atrophy, because atrophy means a wasting away of your tissues. And so to say that women have a wasting away of their vagina, it's just not what you want to hear as a female, right? And so they came up with this name, genitourinary syndrome of menopause, and it's really supposed to represent this constellation of symptoms that women can have. It can be anything from vaginal dryness to recurring urinary tract infections, urinary frequency, urgency, irritation. All of those types of things are incorporated in the name.
So why, it kind of had this other name. Why do you think that it took this long for the kind of guideline panel to come up with these recommendations and start this?
Yeah, so I'll tell you, this is no discredit to my residency training, but I didn't know anything about vaginal estrogen, genitourinary syndrome of menopause, never even heard these words until I learned them from social media. And that is kind of a testament to just the power of social media. And I went through residency in the time of COVID, so I think that's when a lot of the education kind of went to those platforms. And I started following these other female urologists, Dr. Kelly Casperson, Dr. Rachel Rubin, amongst others, who got really loud about these topics. And I think really just with their efforts and their push, did people start to recognize the importance, right? One of the things Dr. Rachel Rubin always would talk about is how, UTIs are killing women. So I have so many women that come to me in my practice with just horrific UTIs where I had one just this week. She's got a PICC line in. She's been on IV antibiotics for 14 days. She's resistant to every antibiotic except for meropenem. And it's like that could have been prevented had we treated her genitourinary syndrome of menopause 30 years ago, prior to her getting to the age of 80. And so, again, just these urologists kind of getting loud about the importance of this. And I think that just kind of built momentum until people started to notice it more and got behind it. So I was listening to a podcast actually earlier this week, and they were talking about how one of the goals, it was an older podcast, they were talking about one of the goals was to actually create a guideline panel on genitourinary syndrome of menopause. And I was like, you've made that goal. And another goal they had mentioned was getting the black box label removed. And we can talk about that later, but they achieved that goal too. And, if you think about it, they did it in a pretty short amount of time, which is super cool.
Yeah.
So talk about the guidelines a little bit for us.
Yeah.
What prompted them and why are they needed now?
Yeah, so there were really no guidelines on how to screen or treat women for genitourinary syndrome of menopause. And so a group of urologists got together through the AUA to create guidelines to educate and really to put the onus on urologists to start screening and treating these women. Because again, if it's a guideline, then you can be tested on it. It's, board tested. And it is something that falls under all of our purview as urologists, there you go, to really understand and be able to screen and treat.
So I would say, in thinking about it, you've talked about this kind of, it gives a name or it gives a diagnosis for these things. And it's kind of it could be a myriad of things. It sounds like it could be recurrent urinary tract infections, vaginal dryness, irritation, atrophy. So that's, I think a beneficial part of this is it gives a diagnosis and many treatments, which we'll get into here in a bit. So I guess, do the guidelines change how we should be thinking about diagnosing this? I guess it does, because it's actually diagnoses it now a new diagnosis, where the other ones were kind of these maybe catch-all diagnoses.
Yeah, so again, like I had kind of mentioned earlier, when I was going through residency, this was not taught. It wasn't spoken about. We hadn't even heard these terms, right? And so now, you pull up on your phone the guidelines for the AUA, and there it is. And so we have something very kind of easy to access. And so we know when women are coming in and, a woman's 60 and she's coming into you with urgency and frequency, that you're supposed to do a pelvic exam, right? And that you don't necessarily just need to put her on mirabegron or some sort of a medication to treat her overactive bladder, but you should actually look at her tissue and see if, and she's going to be a candidate for vaginal estrogen, as all women are, but treat her for the genitourinary syndrome of menopause prior to just treating her for the overactive bladder. So I think it's just,
Yeah. I would say, for urologists who may not feel fully comfortable with this GSM term yet or the guidelines yet, so what's the message here? What would you say to them?
So if you walk into my office now and you are anywhere around the age of perimenopause or you're in menopause, you and I are going to be having a discussion about vaginal estrogen. And so this is what I try to tell the residents now too, is that it just needs to be something kind of immediately in your pocket, readily available for these women because it is preventative medicine. So this is to, start women on now so that we keep their vaginal tissue, their urethral tissue, their bladder tissue healthy and happy for the rest of their life. And so again, I teach all of my women about the benefits of vaginal estrogen, and I start them all on therapy around that time of menopause so that I'm not seeing them then when they're 80 with their PICC lines on IV meropenem for their recurrent UTIs, or, I have a whole host of patients too who come in with interstitial cystitis in their 70s due to significant bladder pain. And then you do their pelvic exams and it's just that their tissues are significantly irritated, inflamed, and would have benefited from, 20 years of vaginal estrogen therapy.
Just to be clear, you talked about the residents having this in their pocket.
Yeah.
You're not literally having the residents carry vaginal estrogen in their pocket, are you?
If they wanted to, just kidding. No.
So this can be probably a hard topic to bring up with patients. How do you usually start the conversation with them?
Yeah. So when you're a new patient in my office, every single patient gets a pelvic exam. And often I'm doing those with a handheld mirror too, because a lot of women just don't know their anatomy. They don't know what their tissue looks like. And so a lot of, my office visits with my patients are really education based. And so we're going through, what does your exam look like? What am I seeing? How does your tissue look now compared to probably how it looked pre-menopause? And so that they can see those changes and really start to buy in on the need for estrogen therapy locally. And so that's kind of where the conversation starts during their actual exam. And then from there, I start to talk to them about all the benefits of vaginal estrogen therapy. So one of the most important things about it is that it really restores the pH of the vagina. And so you want the vagina to live at an acidic pH. This allows the good bacteria, which are called lactobacilli, to grow there, prevents the bad bacteria, the E. coli, the Klebsiella, the ones that can cause infections and irritation from growing there. And so once they understand that, they start to really kind of buy in, right? They've had moms with horrible UTIs. They have friends with horrible UTIs. They themselves have had horrible UTIs. And they are like, oh, I don't want to be like that. And so they start to understand the need for it because this is something that they're going to be on lifelong. So you need to have them educated enough to understand the importance. And then I describe it to them like skincare. So I grew up, my mom has worked for a cosmetics company my entire life, grew up around the skincare industry. And so I look them right in the eyes and I say, hey, you've got a skincare routine for your face. Now that you're around menopause or post-menopause, this is the skincare routine for your vagina. And they all chuckle. After those conversations, usually they're like, okay, now how do we do it? There's a range of treatment options. The one that I prescribe most commonly is just vaginal estrogen cream. This comes in two forms. One is estrase and one is Premarin cream. Depending on patient's insurance, you'll kind of pick one cream or the other. But the point is that you're going to use a grape-sized amount, or 1 gram is what I tell my patients. But I kind of use the analogy of a grape, and you're going to use it twice a week in the vagina. I describe it to them. There's 2 different ways to apply it. It comes with a tampon-like applicator that they can fill up to the gram mark and kind of put it as high as they can, plunge it in, usually at the end of the night. That way it's got time to kind of work through the tissues as the patient is sleeping. Or they can put it on their finger, and I kind of tell them how to fill it up to the first knuckle, and then put it into their vagina. And you really want to rub it into the tissues. So the analogy for that is if you're putting sun lotion on your face, or sunscreen, you're not just going to like slap it on your face and expect it to work, right? So you got to kind of moisturize it into the vaginal tissue so that it has as best effect as possible. And so again, estrogen cream is my go-to. It's the most affordable based on insurance. Even if their insurance is not willing to cover it, Mark Cuban's Cost Plus Pharmacy has the tube online for $11. Or you can use a GoodRx coupon at a cash price, usually for $20 to $30 at most pharmacies. So I'll go through, and my nurses will go through those options with them as well.
What about in women with a history of breast cancer and the safety guidelines around that?
Yeah.
I think that's an important point because, when I was going through residency, that was, there's all these concern, breast cancer, endometrial cancer, giving estrogen. And so that's going to lead us into this other thing that just came out recently as well. So
Yeah. So there's no good data to suggest that vaginal estrogen therapy causes breast cancer. There's also no good data to suggest that vaginal estrogen therapy increases your risk of recurrence of breast cancer. So we have very large population studies, multiple of them now, which show the safety of vaginal estrogen therapy, both in patients with breast cancer or a history of breast cancer. That being said, if I have a patient who's in my office with significant GSM symptoms, and I think they're a good, that they need vaginal estrogen therapy and they are actively being treated for breast cancer, I usually do send a message to their oncologist and we have a conversation about it. I almost never get pushback anymore, which has changed with time, because I think they are all also aware of the importance of this, but also the safety as backed by the studies. So in addition to vaginal estrogen creams, there's also vaginal estrogen tablets. These just are little pills that can be placed in the vagina. Again, this is a twice weekly therapy. This is great for patients who find the cream to be really messy or bothersome. You'll have patients who are just like, I don't want to do that, and that's okay. And so the tablets are a great option. They're just harder to get covered by insurance. Another really good option for your elderly patients who have, difficult memory problems, poor dexterity of their hands, who you're just like, they're not going to be able to do the vaginal estrogen cream. There's an E-string. This is an actual vaginal ring that goes into the vagina, and it gives off estrogen on a daily basis at very low doses, and it stays in the vagina for 3 months at a time. And so I have a whole group of women who, come in for nursing exchanges of their E-string on an every 3 month basis. But that's a phenomenal option as well. Usually you have to write in your note a little bit more detail about why the patient would need the ring, so that you can get it covered by insurance. And then lastly, there's DHEA options. And so this is for your patients who, I guess let me go back. So DHEA gives androgens as well. And so we know that the vagina, the urethra, and the bladder have both estrogen receptors, but also androgen receptors. And so some women, even though they're on estrogen therapy, are just not responding kind of like you would hope they would. And so I found giving them DHEA to be very helpful because you're giving them that androgen component too. This comes in a nice suppository that goes in the vagina called Intrarosa, and you do this nightly. So it's not twice a week, but it's every single night. This is also good for your active breast cancer treatment patients. So if their oncologists still are really like, I don't want them on vaginal estrogen therapy, DHEA is very safe for these patients to use.
So a couple other things in the guidelines that I think is probably a little bit more holistic rather than just come in, get a prescription, get a treatment. It talks about sending patients to therapists if they have sexual health concerns, psychosocial concerns, and even physical therapy for pelvic floor dysfunction. So I think that I appreciate that about the guidelines. I think in today's society we're very much come and get your prescription, go home and take your pills or whatever. And so I think that's a valuable part of the guidelines. Would you say?
Yeah, absolutely. I love my pelvic floor physical therapist because I send a lot of referrals to them. And if you have patients who have had just, again, this pain, right? They've had literal pain in their bladder, their urethra, their vagina for years. It can cause pelvic floor dysfunction. Their muscles get really tight. And then even though the vaginal tissue gets healthy again with estrogen therapy, their muscles are still incredibly tight. And so they might still have, discomfort with intercourse or just pain in general. And so pelvic floor physical therapy is definitely warranted in those situations.
Do you find a lot of skepticism from patients when you talk about that?
No, because I actually went to pelvic floor physical therapy after I had my baby.
Oh, yeah?
And so I find that as soon as I tell them that, they're like, oh, okay, yeah, I'll go. Just, I don't know, again, just building that relationship with your patients, getting them to buy in. I also tell them, you can go once. If you find it to be completely unhelpful, you don't have to go anymore. Or you can go 6 times, learn the exercises, and then say, I'm good, Yeah. So it's not like something that you have to commit to for the rest of your life by any means, unlike vaginal estrogen therapy, which you should.
Talk to us a little bit about, the guidelines. Talk a little bit about these energy-based interventions, lasers, radiofrequency ablation. Talk a little bit about that. Maybe there's maybe some good things, maybe some bad things.
Yeah. So there's not great data.
Yeah.
And that's what the guidelines say basically, is that we just don't have any great data to say, this is helpful. It's often not covered by insurance, so it is a cash pay. I do tell my patients, if they are specifically asking about this, I explain that to them, and I explain the data that is behind vaginal estrogen therapy and DHEA. But if they still want to do it, it's their body. And I think that they have every right to. So I don't think there's a lot of harm necessarily. I just don't know that there's much benefit.
Okay, so guidelines are out, very fresh, very new. Obviously, it takes, anything in medicine, it takes a while to get incorporated into practice. Physicians are largely set in their ways for the most part, and new things come along, they need to be convinced. So I guess for the residents, fellows, APPs, other urologists listening, what should they start doing differently tomorrow in clinic with these guidelines?
Yeah. So if you have a female patient coming to see you and they have any of the symptoms that we've already mentioned that would surround GSM, you need to do a pelvic exam. And that sounds scary to a lot of providers because they immediately think, especially in urology, they think of the POP-Q exam, right? And oh my gosh, I need to figure out where all the points are and what's happening with the prolapse. And that's not what we're going for here, right? When I talk pelvic exam, all I'm saying is that you need to put the woman up in some stirrups. You need to give her a mirror, right? And you need to spread the labia and you need to look at the tissue. And you will find dryness and you will find pallor and you will find, redness and irritation. You will find urethral caruncles. You will find pelvic muscles that are tight. And so it's very important to not overlook doing just a good pelvic exam. And again, it doesn't have to be anything complicated. You don't even have to use a speculum, right? It's just about looking. It's part of the physical exam. And so that would be my first thing. And then once you do that, because it's hard to just have a patient come in and say, hey, you need some vaginal estrogen therapy. And you haven't even looked at their vagina, right? Yeah. It's harder for them to kind of understand why you would be saying that without an actual exam. And so that would be my first point for these residents, APPs, other urologists, would be just making sure that you're incorporating that again into practice. And then understanding that this is now just the mainstay of a preventative medicine for all women around the time of menopause and beyond. And so if you have a woman who's had her first UTI and she's, 53, she needs to be on vaginal estrogen therapy. She probably should have been on it even before then. One of the other important things too that I get asked about a lot is just these patient populations that aren't necessarily just menopause or perimenopause. And so you'll find similar findings with young women on oral contraceptive pills. And that's due to increases in sex hormone binding globulin that kind of bind up the androgens that can lead to similar findings in the vaginal tissue. And so I've taught my APPs that, this actually is a good therapy for those patients as well. Also, if you've had a woman who's just had, one ovary removed but is still having her menstrual cycle but is having these symptoms, you want to be thinking about this. If you've had women who are breastfeeding, that's another one, where just anything that could be causing kind of systemic hormone changes. And so screening those patients in addition. I think we, as urologists, have always been trained to kind of look for interstitial cystitis. And so a lot of my practice is trying to kind of get away from that and more so look at the hormones and how that impacts the overall health of the vagina and bladder.
Moving forward, how do you think these guidelines will kind of shape women's health and women's care?
Yeah, so I mean, there's a huge movement right now to just reshape the whole outlook on hormones in general for women, right? So just in November in 2025, the FDA actually removed the black box label from vaginal estrogen therapy, saying that it was causing stroke and dementia and heart attack. And breast cancer and all of these things. And so I think there's a huge push right now just being like, hormones are actually safe for women. And vaginal hormones especially are safe for women with really no risk. And I know there's a group now too that are starting to look at, well, how do we get testosterone therapy for women? And that could be a whole nother conversation and podcast because I do that as well. But just because we know that that's so important too. And so I appreciate the momentum out there, and I appreciate the movement to kind of get women the hormone management that they need for a better quality of life.
This is a lot of information. If there's, any women out there that are like, I don't know, I'm kind of that age. I don't know what I should be doing. What should I be doing? What's your suggestion?
Yeah, if you're questioning it at all, there's absolutely no harm to starting vaginal estrogen therapy, right? So this is your skincare routine for your vagina. If you think that you're maybe of the age where you start needing it, you probably do. So start it twice a week, white grape-sized amount in the vagina. Keep it healthy for life.
All right, let's ask some fun questions.
Oh, no. That's probably what I'll be worst at.
Wait, did you say you had 3 that you wanted to ask?
Well, they're
Just whichever ones were on there.
Yeah, we'll fly by the seat of our pants here.
I do like this one. What's a non-work related skill that you're good at, weirdly good at?
Gardening.
Green thumb, do you?
Yeah.
Okay.
Green thumb. Started it up in residency. I think I just needed a hobby outside of here. And I had just a really prolific garden, which now I've moved houses since, but my husband and I have had just really good gardens each and every year. Didn't do it so much last year because I was 9 months pregnant, and I was like, I'm not getting down on my hands and knees all summer to do this. But yeah.
Are we talking like
Vegetables?
flowers, vegetables?
Oh, sorry,
fruits?
vegetable garden.
Vegetable garden.
Yeah, like grew huge zucchinis, cucumbers, tomatoes, peppers, lettuce, sunflowers. Yeah.
What's your favorite vegetable to grow?
Cucumbers. They grow like wildflower. They're everywhere, but they're also delicious.
I like it. If you weren't doing what you do now, what do you think you'd be doing instead? Being a gardener.
No. I'd probably be, I don't know, I'd probably follow my mother's footsteps and be some awesome executive at something, running some company. I don't know which one.
Leadership roles. Well, my first question, which we learned that in the pre-interview stage here, that Ramzy apparently doesn't watch TV. I was going to ask her favorite show or movie, so I'm a bit of a loss. Yeah. She didn't watch TV, so she doesn't have one.
Well, no, I do watch some. I watch a lot of football, so go Hoosiers.
Yeah. That's actually we have to take a minute here because
yeah.
I didn't go, many of our faculty, well, I wouldn't say many, but several of our faculty went to the residents went to the national championship game. I did not. But when the TV came on and was showing the field, end zones painted Miami and Indiana, just with Indiana's football history, it was like I stopped what I was doing and just looked at the end zone. I was like, I can't believe this is here.
Yeah.
It was crazy.
Yeah.
It's so cool.
I've been watching a lot of social media posts too that are just like, this is one of the wildest, turn of events in any sports history ever. And they're trying to compare it to other things and we can't even. And so anyways. amazing.
If you didn't have season football tickets, it's going to be a lot harder to get now and more expensive.
Fair. So yes, most of my TV time right now has just been watching football. I will say my husband and I usually like to watch Game of Thrones as well, and sometimes we'll rewatch that. And so they just put out their new series. And we watched the first episode, but not much happened in episode 1.
It gets better. Hang in there.
We'll see.
Well, thank you so much. We appreciate you coming on the podcast and talking with us.
Yeah, we appreciate it. Ramzy's shining star in the field, and we're happy to have her on our faculty and look forward to what she's going to do for her patients and our department.
Thanks for having me.
Thanks for joining us on this episode of Inside Urology. Make sure to follow, subscribe, and share this episode with someone who might like an inside look at the world of urology. And stay tuned as we keep cutting to the chase.